Today I'm speaking with a distinguished panel of experts in dentistry about caries intervention, given we know now that the caries process is a controllable balance between remineralization and demineralization. Our panel will guide us on the use and delivery of fluoride based on evidence and ethical decision making. We know from the Canadian Health Measures Survey that 96% of adults have a history of caries, 57% of children between the ages of 6 to 11 will have a cavity. 59% of 12 to 9-year-olds have or have had a cavity, and severe tooth decay still remains the leading reason Canadian preschoolers have day surgery each year. So before we start, I'll ask each panelist to quickly introduce him or herself, please.
Well, it's a delight to be here with you today, sir. Thank you very much for inviting me. I am Clive Friedmann. I'm a pediatric dentist based in London, Ontario.
I'm thrilled to be here with this esteemed panel, and my name is Joanne Jones, and I am by profession a dental hygienist, an international speaker, and president of an educational and clinical training company.
My name is Robin Duke. I'm a dental sales specialist with 3M Canada's Oral Care Division. Before entering the world of sales, I was a registered dental hygienist for 12 years, practicing in both general and orthodontic practices in Toronto.
Good morning, dental friends. My name is Irene Iancu, and I'm a Toronto-based practicing dental hygienist and educator. I'm thrilled to be here with you all today as a key opinion leader and looking forward to sharing some of my best practices with you. Thanks for having me.
Thank you all for joining us. And before we start, Joanne, you have an interesting video that you have carried out with a neighbor who had some candid questions about fluoride delivery for her child. And this is probably something that is very close to home for many practitioners, as we all have patients and parents that ask us several questions. Can you give us a brief recap of that video?
Absolutely. It was a unique opportunity and ended up being a great teaching tool. My neighbor had been to see her dentist with her daughter who was in active ortho, and there were several areas of demineralization. So the recommendation was increasing fluoride treatments for her daughter. Where she called me in was the fact that she was quite perplexed. You know, there's so much out there on the internet about fluoride concerns, possible toxicity. So as a parent, it was a little overwhelming for her, and she just wanted some clarification.
Okay, so to start, Dr. Friedmann, as a practicing pediatric dentist, how has the delivery of fluoride evolved in your clinical practice over the last several years?
Well, as you know, in the early years, we used to provide fluoride in gel trays and foam trays, and the kids would swallow it, they would ingest it, they would not be able to rinse for or drink for over 20-30 minutes. And then with the advent of the fluoride varnish, that changed dramatically. So with fluoride varnish, we no longer have those issues. Apart from the evidence with respect to fluoride varnish, which shows a much increased reduction in caries rates, up to 43% by some authors, with respect to decreasing decay rates. So the fluoride varnish has really improved our ability to provide care on a much quicker and easier basis. So, yeah. The other thing that I want to identify that's really important with the use of topically provided fluoride professionally is the importance of risk management and risk assessment of the patient. So for moderate and high risk, professionally applied fluorides really does do a phenomenal job at pharmacological treatment of decay.
Now, Dr. Friedmann, how have the updated ADA recommendations for the use of professionally applied fluoride influenced your decision-making or your practice?
Well, as you know, the ADA recommendations are identifying that we should only be using 2.26% fluoride varnish. or 5% sodium fluoride varnish for children under the age of 6 years of age, and that the fluoride gels and foams are no longer recommended due to the toxicity and swallowing of the fluoride. So you have both issues here. You have both the toxicity as well as the efficacy.
Okay, thank you.
And that is something that leads us into our discussion with our parent as well, that may have the same questions as my neighbor had. From a parental side, you know, it's very, very easy to become non-defensive and to put ourselves in the shoes of a parent who is doing some research online and is seeing that there are some possible concerns. What I really like to stand behind as a dental hygienist, as a dental professional, is the fact that evidence is at the very cornerstone of all our decision making. So if we look at those 2006 guidelines by the ADA Council on Scientific Affairs, we can clearly see, and then the subsequent updated 2013 published guidelines, we can clearly see that there is a long, exhaustive, systematic review of clinical trials and research that has substantiated not only safety, but efficacy with clinical trials, with all the evidence that has been presented. We also must look at other credible organizations like the World Health Organization, like Health Canada. And the more recent CDA statement, I believe it was in 2012, Suham, that discussed that for caries prevention, fluoride is heralded as one of the greatest preventive healthcare measures in the whole healthcare system for prevention of dental caries. So again, when we look at the fact that we have the evidence, we have the knowledge, all we now need to do, as indicated by Dr. Friedmann's comments, is put our knowledge into practice with the assurance that we are following evidence-based guidelines.
Okay, thank you. Now, Irene, as a dental hygienist in clinical practice, what is the delivery system that you use the most and why?
Well, I guess I've discovered that topically applied fluoride has been the most successful in my years of clinical practice, which has been about 10 years now. Years ago, I often questioned various fluoride delivery methods and the fact that patients weren't getting kind of the biggest bang for their buck or the most effective use of fluoride topically. With topically placed varnish, I feel more confident, just as Joanne and Dr. Friedmann had mentioned, that science has now backed up topically placed varnish versus foam and trays and rinses. So studies really make me feel a little bit more confident when making these recommendations to my patients based on the various organizations that have published. Lots of pros that I've found of topically placed with varnish as opposed to foams and rinses. Just the quick application is something that most patients are really interested in. The lack of isolation that's needed. Saliva actually sets varnish onto the teeth, so suctioning is not required. And I guess the minimal instance of ingesting, which is more beneficial for patients, and having those uncomfortable conversations with parents as to how the varnish stays onto where we need it to stay and not being ingested. So lots of benefits. In our practice, we really do conduct a Cambria study, so caries risk assessment and management tools. So we like to isolate where caries is coming from. We do lots of salivary testing, pH testing. So we find that with immunocompromised patients as well, whether it's xerostomia that's medically compromised or medication-induced, there's lots of different factors that we take into consideration, and we found that varnish technology kind of is more geared towards those patients as well. And in a practice with lots of young adults and young professionals, we noticed that with orthodontic cases as well, it's a lot better and easier to apply. And again, so it's just a huge spectrum. We also found that a lot of our products were expiring. We were having different products on the shelf, but not using them all. So we've really narrowed down to varnish as not only a gold standard, but also a great spectrum of from young to the young at heart, as you mentioned. So just a simple application that isn't messy. I don't know about you guys, but it's really difficult for me to get a 10-year-old to sit in the chair for 4 minutes still, let alone with the suction in the mouth and foam and don't swallow. Like, it's not so easy. So we've definitely found that varnish is being more widely accepted.
Not to mention the crying, right?
Oh, yeah. And it gives them that indication that, you know, the bad experiences. And for adults as well, it gives them a positive look on things, saying, you know, dentistry is forever changing. So things are always changing for the better. And I think that's what Varnish is doing for dentistry.
So Robin, can you shed some light on 3M's varnish product? What makes it different from other varnishes, and what are the advantages of this product?
Well, 3M Vanish White Varnish stands out from other fluoride varnishes in a few ways. First, like other varnishes, it contains 5% sodium fluoride, but unlike many others, 3M Vanish White Varnish also contains calcium and phosphate. Of course, these are the naturally occurring minerals in our enamel and saliva that contribute to remineralization. So when fluoride is introduced, it combines with these minerals to form fluorapatite, and that's more resistant to acid attacks than calcium and phosphate alone. So few varnishes contain calcium and phosphate. Most are simply 5% sodium fluoride. And one of the reasons is calcium and fluoride combine during storage to form calcium fluoride, and that renders the fluoride less effective. Fortunately, 3M's exclusive and innovative functionalized tricalcium phosphate, or TCP, is formulated with a protective coating, so there's no interaction with fluoride in the package. Basically, the calcium and phosphate ions are encapsulated, separating them from the fluoride ions. And once 3M Vanish White Varnish is applied to the teeth, the saliva dissolves that protective coating, making the TCP and fluoride combination bioavailable, which essentially means it's easily absorbed and used for remineralization. Another benefit of 3M Vanish White Varnish is its ability to migrate. So once it's applied to the teeth, the product will spread interproximally where a microbrusher applicator cannot fit. It's also sticky, and that's a good thing. So you want the varnish to stick to the teeth instead of being ingested. When the clinician applies the varnish thinly as directed, the stickiness does not interfere with the ease of application. And finally, 3M Vanish White Varnish is sweetened with xylitol. And of course, we know that's a natural sweetener that helps maintain a neutral pH in the mouth, and it also prevents bacteria from sticking to the teeth. So the exclusive and innovative functionalized tricalcium phosphate, the ability to migrate interproximally, a consistency that remains on the teeth until brushed off, and sweetened with xylitol, all make 3M Vanish White Varnish an essential part of any clinical prevention program.
Okay, thank you, Robin, for those highlights of the product. I have one practical question to ask either Irene or Clive, and you can both weigh in on this. How do you explain the stickiness and that feeling that people leave with to your patients?
The thing that I've noticed is that oftentimes as hygienists, we use one technique for placing a product in the mouth interchangeably with others. And I know this for a fact because I was demonstrating the application of Vanish Varnish to a fellow hygienist that was new and had never used it before. And her immediate response was, well, how come you don't place it on the lingual? And I said, well, because this material migrates. And I think, correct me if I'm wrong, Robin, it's up to 4 millimeters within the first 5 minutes. And it stays on the teeth for over 4 hours. So it might be just a technique thing from one hygienist to another. We also sometimes feel that more is better, but in this case, it's not the case. The teeth only need as much as the teeth need. So a thin sweeping motion from posterior to anterior. So oftentimes it's a technical thing. It's an application thing that could be easily corrected. So I know Robin uses the term thin to win. So think of it as a thin sweeping motion. And at that point, you know, the saliva will really set that thin layer onto the teeth, not making it as sticky as we'd like to think it should be.
Can I add something to that, Suhan? I also concur exactly with what Irene was saying, and in my lectures I always include the video, because think of the dental professional, think of our characteristics. We tend to be perfectionists and very, very thorough, and when I've watched in practices some dental hygienists applying it, they scallop it and they go over every area so carefully, and it ends up being very, very thick on the tooth structure. So I love that thin to win, and I think that should be the mantra to Vanish Varnish, so that everybody understands that it really is quick, simple, and very almost imperceptible to our patient afterwards.
Thank you. Now, would anybody like to make any closing remarks about fluoride varnish, and its use in practice?
I think I would just like to highlight, Suhan, the importance of the balancing the pathological and the protective factors when we're talking about remineralization and demineralization, and that fluoride in terms of the evidence is the highest with respect to the protective factors. So the other piece that I would like to identify is that for many individuals, they look at white spot lesions, or what dentists call incipient lesions, which really is a misnomer, because white spot lesions are lesions. If we look at the ICDS classification of disease, stage 1, 2, and 3s are absolutely appropriately treated with a fluoride varnish and not with a surgical drill and fill. So this application of a biological material, I think, is superb.
Thank you. Well, I thank you all for joining us today and giving us your insights and sharing your experiences and information. It's been very valuable.
Thank you.
Thank you.
Thank you.